So I will start by introducing our first moderator of this panel today, who is Jessica Rose. She is a senior health systems and M&E advisor in the Office of HIV/AIDS at USAID, with over 20 years of experience in global health. Her career began here in New York City when she was a candy striper at Lenox Hill Hospital in the early days of the AIDS epidemic. She provides support to PEPFAR and the Office of the Global AIDS Coordinator to develop goals, implement plans, and measure progress for human resources for health. She has an undergraduate degree in political science from Johns Hopkins University and a master's from the Harvard School of Public Health. So I will hand over to Jessica.
Good morning. I'm going to just do a quick intro without hurting myself. In terms of being a moderator, I'm just here to do a couple of brief intros, and I'll let the speakers speak for themselves. So I think any symposium about measurement is good for me, so I'm thrilled to be here. I think this is also a very timely meeting in an era of diminishing resources and tightening budgets, and I think also looking for efficiencies in what we do. Measurement's sort of the key to that. And in addition to that, understanding the impact that we're having globally, I think is very important. So it's very timely discussion, and I'm thrilled that we're having it. I think some of the issues that you're going to hear about today from our panelists, we'd like to identify a lot of the issues that they're grappling with, the challenges that they're facing, and the work that they want to achieve. And then maybe how do we monitor that? It's all a bit challenging, and there's a lot of quantitative and qualitative work that needs to be done. I think it's important as a measurement person to think about your data sources. I think that's a really big part of this. And then I would say also very importantly, understanding who the stakeholders are, who the other stakeholders might be. That's going to help us in data collection and analysis, understanding what the information means, and then I think using that and applying that for better programming. So I'm going to stop right there because I think, again, we want to give plenty of time to our speakers. First up, Jim Mccaffrey. His bio is over there on the wall, but I can vouch for him personally. Worked with him for several years, and he's definitely an expert on this, and I think he'll have a really insightful presentation.
Thank you. Talk amongst yourselves. Okay, so this works, and then that.
And then you just have to, you have to advance
Okay, I don't know, is the microphone, can you all hear me? Can you hear me? Did you raise your hand? You can't hear me? I'll talk louder, you can hear me? Just curious, how many of you are students in here? Great. All congregating at one table for the most part. We had a wonderful discussion last night with one of your faculty members who said, students are often curious about how did you get where you are? What did you major in? So I will tell you that I'm a history major. It has absolutely nothing to do with what I'm doing here today, but it was fun when I was doing it. When I joined the Peace Corps after that and spent the next 5 or 6 years working in various countries overseas, got very interested in international work, and then went back to graduate school, got a PhD in education and organizational behavior. And that's sort of my sort of niche with this world, and it's around organizational change. And in that, I've worked in the health sector for the past 15 years or so. And really focusing on the workforce. And it was, when I got started in this, it was a time when there were many vertical programs, HIV programs, reproductive health, malaria, and they were often funded by a variety of donors, plus country-level governments, to develop new programs. And they developed really fine programs, but with very little regard to who would actually carry them out. So they would do it on a pilot basis with a carefully selected and trained group of healthcare providers, and then assume that once it either worked or worked mostly, that then it would be automatically scaled up. But there was a big problem with that, and that there weren't enough healthcare providers. So about 2004, there began to be quite a bit of research around it, and trying, first of all, trying to measure what do we have. And there's some interesting statistics because we think about measurement. Originally, we think about numbers. So one number that has always struck me, this came from the Global Health Workforce Alliance in 2011, that is 1 billion people will never see a skilled health worker during their lives. Obvious implication there around health and access and quality of life. In 2006, the WHO kind of dramatized this by doing and collecting data from all over the world and looking at the ratio of healthcare providers to population and tying it to a couple of health indicators. And they came up with a ratio of 2.3 healthcare providers per 1,000 in the population, and anybody that was below that was considered to be in crisis. And there were 57 countries with a health workforce crisis at that point. And so that went on, and obviously lives were in the balance. The workforce crisis in the health area had these sort of some causes, not all of them. There was an absolute shortage of health workers. There was inequitable distribution. It was hard to attract people and retain them in certain areas of countries, big gaps. There was health worker migration and flow both internally in the country, in sub-regions, and from south to north. There were weak human resource management systems, a poor work environment, and there were leadership and advocacy issues. And they all contributed in one way or another to the health workforce crisis. So, the whole idea was, well, we need some measures of the workforce. And it's a key factor because everything starts with that. Everything starts with that kind of, who are they, where are they, how many, who provides which services, what gaps. What gaps are there in the workforce? So there's, again, basically it's looking and mapping what exists and what doesn't exist and what are they called and what are they doing. And then it's not just about the numbers, because then you can take a look at when you begin to get this statistical data, it obviously raises issues. And then you got to say why. And how do we find that out? And that brings in qualitative measurement as well as quantitative. And you really have to have both, otherwise you're severely limited, because you can note that there are gaps and that there are no physicians in a certain part of certain districts in the country, but if you don't know why, it doesn't do you much good. Or if you guess, and you guess wrong, it doesn't do you much good. And also, you need to look at trends. So what does this data look like, not just one time, but over time? I'll give you one example from Uganda. This was sort of a snapshot taken in 2009, and it's a percentage of approved positions filled. And what you have is, with the red is 0 to 35%, the sort of mustard color is 35 to 50, and so on. And the green is 70 to 100%. And as you notice, if you could probably put Kampala in one of the green areas, because a lot of the physicians and a lesser number, but certainly a lot of the nurses were located in and around Kampala. And there were a number of districts, at that point when this was done, they had 85 districts, and there were a number of districts, probably 20, that had no physicians at all, and might have one nurse or a clinical officer performing certain kinds of functions, often performing beyond their kind of scopes, because they needed to. So that map was there. That was good. It took 2 or 3 years to begin to get this data because it doesn't exist automatically. It's housed in professional councils, at the universities, sometimes in the immigration office. So it's all over the place. And it wasn't routinely collected. And another thing, it was often collected only from the government providers. And as many of you know, in sub-Saharan Africa and certain countries, the faith-based organizations can provide anywhere from 20 to 80% of the healthcare services. They weren't often counted in this. But this then was used. How is this useful? Well, for advocacy. At the global level, the first statistics I gave, gave a real impetus to people who wanted to argue for a greater support of investment in the healthcare workforce. And that was support on the part of WHO, the Global Health Workforce Alliance, and a variety of both multilateral and bilateral donors who had this now as a very powerful picture to push for more investment. At the country level, you just saw that map. And that was presented as part of a large-scale meeting within Uganda. And it led to these questions. Who is doing which tasks then? If there are no physicians in certain areas, if there is one nurse where there should be 6 nurses, if clinical officers are, who's doing what? What are the most pressing gaps? How can workforce data better inform decisions, and which stakeholders need to be involved in planning? All of those then led to discussions over a period of a couple of years around what do we do about this? And especially that last one, the faith-based organizations were finally brought into discussions around this because what they did and what the government did reverberated. And so if the government decided to take certain actions around a healthcare worker, around compensation, that would often mean that people might leave some of the faith-based institutions. And the faith-based institutions were often in rural and hard-to-reach areas, and that would leave big gaps. So they began to say, we need to talk more together about this. So that was 2009 there, and here's what it looks like in 2013. It's a long-term process. This stuff doesn't get handled in a year-long or a 2-year-long project, but you can see that there have been some real investments, some real progress made in trying to fill positions that are allocated, that were funded, but were left open. And the kinds of interventions involved everything from looking at streamlining the hiring process to getting more sophisticated about how do we attract people to these more rural areas, what kinds of incentives do we offer, and so on. So to me, that was an example of that. A couple of other areas around data being useful. And when I talk again about data, the numbers are very important, but the qualitative data is very important because it helps to determine why. So developing, if you have a workforce, how do you continue to develop it? In the health sector, it's sort of how do education and training outputs in terms of the schools that exist or the training institutions align with service delivery needs. Often they weren't aligned with it. They were producing kinds of workers that really weren't needed, and there needed to be some kind of adjustment and change process to go on to look at what services are needed where, what competencies are needed to deliver these services, and how do we then train and educate people to do these. And they needed to do that. They needed to look at the effectiveness of their medical and nursing schools and their other training institutions for allied health professionals and look at blockages to expansion. And they did in Uganda and in other places. And then finally, the supporting. Once you have the workforce there, how do you, how do you recruit and attract, and then how do you retain people? And this is an area that is really big around the importance of qualitative data, because if you have a maldistribution issue in terms of where people are in the country and what kinds of providers are where, you need to get qualitative data to find out why aren't people going and what would it take to get them there. And at first, this was simplified because people didn't have that data. They said the problem was compensation. They just aren't getting enough money to go to these places. And so there are various examples from countries that basically raised the physician salaries and compensation and incentives, and it had a short-term impact but not much of a long-term impact. And when they began to dig deeper and do something around what it would take and use tools around research to get qualitative data, they found out that there were issues of new graduates being sent to places that had no supplies, no materials, no running water. And they said, why would we want to go there? We just spent 6 years learning how to do something, and then we go out there and we couldn't do it. Now, you can look at that in two ways. One is you could say, maybe we got to look at our training and saying, maybe we should train them to operate in those. But basically, there's a supplies and materials issues. There is housing, where do I live? There are issues of transportation. And then some popped up that people were initially surprised at. I don't know why, but it was career progression. Where am I, how does this fit with some kind of career? And there was some sense of professional networking. If I'm sent to a rural area, doesn't have good communication, and you forget about me, and I'm there for the next 10 years, I don't want to do that. And so they began to get a lot of really good qualitative data, which could then inform policy decisions. In terms of the education one, just an example from Nigeria, where they discovered around community health extension workers and midwifery students that there were gaps, big gaps, both in terms of, again, absolute numbers and where they were. And one part of that solution was around trying to strengthen the schools. And again, looking at what the data they got, there were problems with the tutors, there were textbook problems, there were issues around how do we network kind of the people that have the knowledge more actively to get involved. And so there was an effort to do something like this, but this was all based on the kind of qualitative and quantitative data that came out of it. So in the HRH world, there's been progress around strategic plans, human resource information systems that are being strengthened and growing. Human resource management, production is kind of getting better. There's more data becoming available about attraction and retention, and more of a sense that we need to ask the people that are going out there what their dreams are, as well as where they want to go. And there's an increasing need for partnership mechanisms. Now, some of these are the same kinds of needs that you're going to find in the social service workforce area. And that was the last thing. The lessons that I'm kind of seeing, because I've spent the last 3 years working in the social service workforce area. First of all, coming from the health area, it's a long-term issue. So you really have to be in it and see it that way. More human resource information is needed. It's a high priority need. There's actually some good progress being made in many countries about mapping the workforce, and this is good. All of this can be used for advocacy, to inform policy and action, and to build a knowledge base. A holistic approach is needed, and partnerships at all levels are probably needed even more so within this sector, where civil society and NGOs play even a larger role than they do in the health sector. And lastly, and this can help maybe foreshadow the next two speakers, we have to keep in mind that this is in many countries, as we're focused on low and middle income countries, many of the low income countries, they're scarce resources, really scarce. And I'll end with a little anecdote. 3 years ago, we had a meeting of the deans of several medical schools, and we got into this discussion about the need for obstetric care in outside the capital cities and so on, and how to get it, and what kinds of, there aren't physicians there, and what kind of tasks could be shifted. And the dean of one of the schools in Ghana adamantly said, we do not deserve second-class treatment. We need a physician. If somebody's having an obstetric emergency, we need a physician at that time to do it. And everybody said, yeah, that's what you need, but there aren't any. There aren't any in the northern tier in Ghana. So what do you do about that? We never got very far in that argument, because he just said, well, there should be. And that's where that one ended. It's progressed since then. But I would just say, as you think about the rest of this panel, be thinking about what happens if you find, when you get this data, that people are doing things beyond their scope of practice. What do you do with that? And what kinds of tasks can be legitimately transferred to different kinds of providers? And I think it's true both in the health sector and in the social service sector. So, thank you.
Sorry.
No, that's fine.
Should I just go on?
Yeah, I'm sorry.
Sorry.
Well, Jim knows Helen better than I do, so I thought I would just let him tee you up.
That was
Yeah,
great.
Brian was over there. And since Jim can vouch for Helen and I can vouch for
exactly.
Jim, I think that's a transitive property in geography. Therefore, I vouch for Helen.
Since my head of department is here, hopefully, John, you can vouch for me. Kind of just sort of pay it forward. So, when Mark and I discussed me presenting here, I'm going like, well, what have I got to offer? I know nothing about CPC, I know nothing about child protection, but I do know a little bit about how do we think about a cadre that is perhaps not necessarily always that recognized within a system, and how do we incorporate that cadre into the system. And much of my work, and I sort of toyed with this idea of what do I call this session, this presentation. Do I talk about task shifting? Do I call it beyond training? Do I call it bringing voice to the voiceless? That just sounded so kind of, I don't know, pathetic. So it's about kind of thinking about, and Jim, thank you for teeing this up so beautifully, because it's about thinking about task shifting, but also about the people involved and what are the systems. And I haven't done as good a job of linking that to the social services, so I'm going to talk specifically from a health perspective. I also want to acknowledge the work of Shannon McNabb, who is my colleague in this work, and I have borrowed shamelessly from her slides. So let me just talk a little bit about who am I talking about. And we were talking about the associate clinicians, and you may say, ooh. And these are the people that Jim kind of referred to a little bit about. Who are the people who are actually out there doing the emergency C-sections and doing some of the clinical work? And often they're talked about in the negative. Well, they're the people who are not doctors, but they are doing the clinical work. They're the people that you know as clinical officers. They're you people that you know as physician assistants in this country, who are now becoming known, I notice with the new Healthcare Act, as the physician extenders. But I think that there are certainly the people who have these basic to advanced competencies to diagnose and manage common medical, maternal, child, and surgical conditions. So they have training. They are health professionals. They're in high, middle, and low income countries. So they are not the second-rate care. They do not provide the second-rate care because they're just in Africa that the Ghana person may well have been referring to. And I think there's this mindset of trying to change who they are and bringing it to all countries rather than just saying it's a poor Africa thing. And certainly we know in the work that's done in 2008, they're in more than half of the countries in sub-Saharan Africa and increasing. So we know that South Africa has just started training associate clinicians, they call clinical associates. South Sudan are beginning to train. There's a whole group of countries that are now thinking about how do we deal with this problem of not having doctors or the maldistribution of doctors. How can we use other cadres who often exist, how can we extend their work? And in some of the work we've done is that we see that they're generally based in the rural area. They have higher retention rates with similar outcomes to physicians. So this is who I'm talking about today, these clinical associates. And we've seen this increase in attention to associate clinicians, and I kind of muddle the name around. This is the collective now. They used to be called non-physician clinicians, what a ghastly name. But now called collectively associate clinicians. But if you're in Malawi, you will know that there are clinical officers, or if you're in Tanzania, they're the clinical officers or associate medical officers. And we've just been doing work in Zambia, and they're the medical licentiates or the clinical officers. I think there's been a lot of attention paid to task shifting and task sharing, certainly in HIV, but not so much in other areas. And I think there's still a lot to be learned. So how does that fit in with what we want, why I'm here today, is really thinking about what can we learn from that process, and what measures have we used, and how have we understood the problem in a holistic way to say how can we strengthen this particular cadre to get the outcomes, because ultimately we want to make sure that we're getting the health outcomes that we are looking for. So the associate clinicians really face these unique challenges, and this might have some resonant with the with social services, of not having a very clear understanding of their role within the system and within the team, of regulations and laws that don't necessarily reflect their scope of work, of what they're trained to do and what their regulators do and what they're actually doing. And I think for me the reason why I have such passion for this is that there's just such a limited voice that they have at any table, so that they're seldom represented by their own. You seldom see clinical officers high up in ministries of health, and you almost never see them at WHO and other kind of global bodies. Some of the consequences that we've begun to see is sort of concerns about if they're not representative, if they don't know if people don't know who they are and what they're meant to be doing, then we're worried about their levels of motivation, what support and supervision they have, their productivity, and the kind of mobility regionally and globally. So I want to take a step back and just say, well, how have we framed up our thinking about addressing some of these issues through the research that we're doing? We go back to a framework that I'm sure Jim will recognize, and many of you will recognize around the table, which came out of the Joint Learning Initiative, which is how do we think about resource actions in terms of numbers, in terms of their satisfactory remuneration, work environment, system support, their skills, training, leadership. How does this translate into the objectives of any workforce around coverage, motivation, and competence? How does this then link to how they perform within any system, be it social or health, in terms of ensuring equitable access, efficiency and effectiveness and quality to get the outcomes we're looking for? So this was one of the frameworks that we used thinking about our research. And then we went down to basics, saying, what are the inputs into this workforce? What are the processes to support? And what are the outcomes we're looking for the health workforce? In terms of inputs, we looked at, when we wanted to understand this cadre of associate clinicians, we looked at what resources go into this, what training opportunities. What are the processes? How do we get a measure on whether there's good processes in terms of management support and workplace relationships, whether they're experiencing fair and just treatment? What is their motivation in terms of matching capability and workload, looking at their burnout, and then ultimately their job satisfaction, and then some measures of outcomes rather than, outputs really rather than outcomes of what is their performance and their retention and commitment. So this is how we then went ahead, and I'm going to present two sets of results. One is work that we did initially in Mozambique, Malawi, and Tanzania, where we did a huge, we continue to swim in the data. Let that be a lesson, never be overextending. But we really wanted to try and get an almost 360 understanding of this cadre so that we could actually do the kind of advocacy, bring voice, strengthen that workforce. That was done, and then I'll talk a little bit about the work we're doing in Zambia to understand in more detail how to implement task shifting. So first we're just looking at the cadre, and then we're looking at, well then how do we do this? We had a whole lot of different data sources because we felt it was important to look at and examine the associate clinicians at the ministry level. And Jim, thanks for focusing and talking about the importance of qualitative, because it's that textured understanding of how do people even understand this particular cadre or group of people that you're trying to strengthen. Looking at the training bodies, the regulatory bodies, thinking about the different levels of the health system wherever you may be, but where we were talking about the district level, understanding the facilities. And this, just to say, was in the context of providing emergency obstetric care and in the work that the Averting Maternal Death and Disability Program where I work is doing. And then really understanding what the providers were feeling in terms of doing a full survey, which included burnout scales, job performance satisfaction scales, work index, their perceptions of their environment, as well as critical incidence analyses. We kind of did it all. And then using that data to try and triangulate and really get a deeper understanding of some of the issues, to try and identify those leverage points where we could begin to act, and then also understand what is going on at the lower level in terms of at the facility might have a knock-on effect higher up and vice versa. So that was kind of how we conceptualize this. So let me talk a little bit about the data. So if we just, and I'm going to just give you some snippets of information. So here's a very basic thing. So if we're looking at inputs, what resources were there for people to work? I know the staffing levels, I think Jim has already referred to, but let's look at the structure and drugs and equipment. So this is a slide which was taken from the facility survey in Malawi, where we just wanted to see what percentage of services had basic drugs and equipment to do the work that was necessary. And so what you see here is, and let's focus on the district hospitals, which and the Christian health, the medical hospitals, the faith-based organizations, of what we can see, how many of those facilities had just the items required. Apart from the central hospitals, N equals 2, so let's just ignore that for a moment. But you can see for the most part, less than 50% of people, of the facilities, had just the necessary drugs and equipment to do the services. So we're putting people into that situation where they're already disadvantaged. And the kinds of things that were missing were pretty basic stuff. It wasn't like we were asking for sophisticated items. We found that they were pretty basic items. That so is there an enabling environment? We begin to question this. So that's just an example of some of the information we got from inputs. We look at the processes, just to pick up on two things. One is a big piece around supervision, and supervision was very broadly described. But what we found is that less than in Mozambique, the supervision, there was some formal supervision. But in Malawi and Tanzania, there was very little formal supervision. In other words, people did not receive some kind of structured supervisory visits. There was nothing there. And so there was a mixed picture around people receiving supervision. And you'll see how this plays out later. And a confession, this was from somebody in Malawi saying, we just don't have the good services. There's no good mechanism for supervision. Jim, you mentioned opportunities for career advancement, and this is an enormous problem amongst the associate clinicians, because here you have this kind of cadre who's in the middle. Where do they go? And overall, and this is in Malawi, 53% of the respondents felt that they had some opportunities for career advancement. But look at how low it was for the medical assistants and the clinical officers. And this is a huge factor in demotivating the associate clinicians in that area. So that gave us some ideas. In terms of outcomes and results, the factors affecting job satisfaction were around adequate supervision, support from management, adequate pay for work done, opportunities for career advancement. But that's just a laundry list. But when we sort of dug down deeper, that the lack of management support outweighed concerns regarding pay threefold in their contribution to job satisfaction levels, with which we really didn't coordinate, but we know each other well. So again, this is the information then we can use. In Tanzania, we asked, in terms of outcomes, people actively seeking other employment. This was for me very telling, because if we focus just on the blue and the doctors and the clinical and the associate clinicians, almost 30% of doctors are actively looking for other employment. But look how low it is for the clinical officers and their AMOs. So there are many reasons for that, but it is interesting that these are people who are wanting to stay. So we then went on to say, well, how much alignment is there? And the green means that there's good alignment between national expectations of what people are going to do and whether the regulatory bodies, pre-service training district, and actual performance lines up. And what we can see here is there's good alignment. So medical doctors, and in fact the clinical officers in Malawi, people understand what they're meant to be doing, is good training in district expectations. What's concerning is the medical assistant, who is also an associate clinician. There's no alignment. People aren't, they're just, no one knows what they're meant to be doing and whether they've been training appropriately. And it's as messy in Tanzania. So very quickly, our research in Zambia, here, so that gives you an idea of kind of understanding the situation in Zambia. What we're trying to do is, well then how do we think, based on all of that, how do we think about implementation? And how do we strengthen the existing program in Zambia and take lessons? Why Zambia? Because it's the country that is most recently, has a recent understanding of task shifting from clinical officers to medical assistants for obstetric care. Some of the things we are doing, and this is work in progress, is around qualitative data collection, provider survey at all these levels. One of the first things we did was do a historical timeline of understanding who are the partners and how are they involved, and this allowed us to identify what went on and who to interview. What we're finding, these are just some quick findings, is that there's a flexibility and local adaptation to support medical licentiates who are their associate clinicians. So again, with the kind of research, we're understanding how can you successfully implement. We're seeing that 70% of the medical licentiates are providing C-sections. Where they're not, it's because of infrastructure. They are not actively seeking other employment. They are well distributed throughout Zambia. I'd be interested to see a doctor map there. What's interesting here is if we look at this, does this mouse show up there? No?
Yeah.
It does, okay. So if we look at their burnout scales here, if we just look at their levels of personal accomplishment, do they feel personally accomplished in the work that they're doing? They're extremely high. But are they emotionally exhausted? Yes. And that's really of concern. That we're finding there's a lack of alignment between policy and practice. 50% of people are performing duties outside of their job description, and there's a lack of career progression opportunities. So it's an inadequate incentive. So I think what's coming next is how do we think about, we've got a good handle now on some of the challenges, how do we think about addressing them? I think for me the more exciting as well is in terms of how have we used this data for advocacy. This is not showing you a picture of me, but more important to show a picture of David Lusali when we were at WHO. And this was the first time that any associate clinician had sat at WHO as a medical licentiate, as an associate clinician, to give input into a very important document that came up. And the first time that WHO has really included associate clinicians as part of the cadres providing maternal and newborn care health. And so, that there is movement. The other exciting piece is the development of the African Network for Associate Clinicians to start giving them a voice. So things are shifting. There's lots to be done, but let me stop there because I know I'm out of time. Thank you very much.
Looks like we lost her. We're going to shift gears a little bit, going from the clinical health practitioner to the clinical law practitioner. Jane, again, her bio is over there, but just to give you a brief background, she's with the university's law school, has worked on needs and rights of children and families, and has lectured to lawyers, social workers, and other mental health professionals. And so her focus is more on the legal aspect of it, of child welfare. Okay, it's all set up.
Yes?
All right, you're good.
So thank you. So I'm switching gears significantly. We tried to figure out how to meld this, but it didn't quite work. So, so I hope you'll be patient, because what I'm going to try to do is give you some lessons about what not to learn from the U.S. child protection system, about how to measure the effectiveness of the social service workforce. And I'm going to do that by talking about how I think our system doesn't work, and because I think we're asking the wrong questions. And maybe I think that will prove useful later in the day as, and I'm sorry I won't be here after lunch, when I think there will be discussions about how to teach about these issues, but here goes. So as a lawyer in the U.S. child welfare system, the effectiveness of the social services workforce is usually measured from the perspective of whether, in the context of an individual legal case in family court, a social worker or a caseworker has followed the rules. Did she meet with the client the requisite number of times? Did she provide the ordered services? Did she make the right referrals? Did she ensure that visits were made? Did she fill out the right forms within the right period of time? Following these rules has become the way for a judge to determine whether the caseworker has done her job. If the caseworker has followed these rules, the judge usually decides that she has done her job. The quality of the work is rarely measured and rarely matters if the rules are followed. In other words, the outcomes for the child or the family are not measured. When child welfare systems are sued for failing to protect children or serve families, these same kinds of measurements are used to create a structure for reforming the system by connecting the workforce resources with these tasks. How many caseworkers are needed to make sufficient numbers of contacts, fill out sufficient numbers of forms, make sufficient numbers of referrals? How much training is necessary to do this? How many resources are necessary for recruitment or retention to improve these outcomes and then to maintain them? Again, the presumption is that by putting into place a structure with sufficient rules and then funding it sufficiently, this system will ensure that the job will be done, maybe even well done. Some impact litigation that is focused on workforce issues has seen improvements in the workforce. Some cases have actually seen improvements in outcome measures for children, but the complexity of the systems makes it hard to identify the reasons for these improved outcomes. Interviews with stakeholders in jurisdictions where reform litigation has occurred has indicated that the four most important factors for improving the workforce were the leadership of the agency, the resources, attention, and pressure that resulted from the litigation, budget considerations in the jurisdictions, and support or resistance to reform by social workers and their supervisors. Yet these four factors have been at the heart of all child welfare reform efforts since the federalization of child welfare in the 1970s, whether they were brought about by impact litigation or more likely just by systems reforms done by the states, generally when there's been some tragedy and there's a decision to reform the system yet again. My point is that these reforms have ultimately failed throughout the country because they have tried to create rules to fix a workforce doing the wrong job in the wrong system. Establishing rules is not a bad idea. Rules help everyone to set standards, to diminish too much discretion, and to combat bias. But measuring whether these rules have been followed tells us almost nothing about whether the caseworker has been effective in her job, if her job is the safety and welfare of children. Most people in this room know that the concept of child protection in the U.S. is a narrow one. Child protection around the world and incorporated into the Convention on the Rights of the Child is broadly defined to encompass all aspects of the child's life and well-being. In the U.S., child protection is narrowly defined within the legal confines of a system that investigates whether parents are maltreating their children to the extent that the state needs to intervene, either to provide specific services to allow the child to remain at home or to remove the child temporarily or even permanently from their families. This narrow definition has resulted in a myopic view of child protection, leaving the U.S., for example, near the bottom of the industrialized world in terms of the well-being of children on every scale. So we are 26 out of 29 among the richest nations of the world in the latest report from UNICEF that was issued last April. This narrow perspective of child protection fails to recognize a broad concept of child well-being shared by family, neighborhood, community, and state. But even if we accept that we are not broadly addressing child well-being in our child protection system, we have to understand what is preventing us from measuring the effectiveness of the workforce within our narrowly defined child protection system. What we measure is the effectiveness of an accusatory system of reporting and investigating, which is based on shifting concepts of what constitutes maltreatment. Because these definitions of maltreatment shift over time from state to state and even within states, it's very difficult to measure workforce effectiveness beyond the ways we currently do. So James Garbarino has called our definitions of maltreatment, quote, a kind of negotiated settlement between science and professional expertise on the one hand and culture and community values on the other, unquote. I would add that that negotiation is fraught with political influence and fiscal decisions that have little to do with protecting children. For example, when is circumcision abuse and when is it an acceptable religious or health practice? How do we view ignoring or punishing childhood actions like bedwetting, thumb-sucking, or temper tantrums? How do parents address their teenagers skipping school, having sex, taking drugs, playing violent video games, or just being sullen? How we answer these questions greatly influences the decisions made to determine whether a parent is placing a child at risk of harm. In Colorado, now smoking a joint is legal. I have a client who is charged with neglect for smoking a joint. Shifting definitions. Since 1974, for 40 years, the U.S. has worked under a system of mandated reporting that engulfs any other concerns we might have for child well-being. Dr. Gary Melton has perhaps more than anyone else in the past half-century in this country tried to convince us that we have created a reporting and investigating system that neither accomplishes its own goals of keeping children safe, nor the broader goals of supporting families trying to raise their children well. As he puts it, the CPS reporting system, quote, responds to accusations, not needs for help, because the principal statutory duty in most jurisdictions in the English-speaking world is to determine whether legally cognizable abuse or neglect occurred, not to eliminate the situations that threaten children's safety, unquote. Even if social workers were perceived as assisting a family prior to the creation of this reporting system, now the worker has become an inquisitor, building a case against a parent that may result in a legal proceeding. Moreover, other professionals and neighbors have been socialized to believe that if they file a report, they have done their duty to help protect children. This further undermines a sense of community and responsibility and shifts the burden to a system that has failed to protect children itself. The combination of having a shifting definition of maltreatment within a system focused on accusations and blame has resulted in significant disparity in applications and outcomes. So I'm going to give you a concrete example of of this, and you can see how difficult it is then to measure. When parents are investigated for abusing or neglecting their children, the investigating caseworker has to determine whether there is enough evidence to substantiate the report. That determination will usually lead to a case being filed in court. So states have radically different substantiation rates for neglect and abuse. In 2009, for example, Massachusetts substantiated over 30% of its cases, while New Hampshire substantiated fewer than 5%. Children in New Hampshire can't really be 8 times safer from parental misconduct than children a few miles to the south. They aren't. Each state creates a system of reporting, investigating, substantiating, and providing services that impacts the state's rates. New York, for example, in 2013 had a very high substantiation rate, over 40%. That rate was because there's a very low standard of proof in New York, only some credible evidence, and a very high quality of investigations. In New York City, the Child Protective Services workers have only 9 cases at a time. The national standard from the Child Welfare League of America is 12. In Arizona, many of you know, the system has totally fallen apart, and at the time it had 70 cases at a time. So you can see that the range of the way in which a system is set up has a great deal to do with whether a case is substantiated. Despite the high substantiation rate in New York has also a very robust system of preventive services, keeping many children at home despite a very high substantiation rate, and most tellingly, keeping the rate of re-reporting quite low. And many would consider that a great success story, and in many ways it is. But at the same time, 60% of the investigations resulted in no substantiation. And unfounded investigations can still lead to stigmatization, family and community disruptions, invasion of privacy, loss of employment, and even unnecessary removals of children. This is compounded by the fact that race and ethnicity influence perceptions of child maltreatment. African American families are more likely to be reported to CPS and have disproportionate numbers of unsubstantiated reports. How substantiation varies so dramatically from state to state is only one example of why I think it's so hard to measure the effectiveness of child protection workforce. The core problem is that we have an ever-changing understanding of what constitutes maltreatment in an accusatory system that requires caseworkers to label perpetrators rather than support them. What constitutes maltreatment is socially and politically constructed and filtered through explicit and implicit biases. So my point is we need to be asking a different question in a different system. How do we protect the whole child by providing for the child and family's well-being? How do we develop and train a workforce for this purpose and then measure their effectiveness to assist fragile families? It's not being done. It is being done. It's just not being done here. So the bottom line lesson is that the current way we measure workforce effectiveness doesn't tell us much about child protection. Jim raised the point that we need to align education with services, and one of the questions I then have is, in the social work profession, do we train social workers, in fact, to do this kind of work? I don't think so. I think we train social workers to work with families, and then we send them into a system, which is an accusatory system, in which it is not aligned. Their training is not aligned to do the work that they're then actually being asked to do. And then they don't do their job very well because they're neither trained nor supported to do the job in which they're actually being asked to do. Helen raised the question about task shifting as well. I also think if we were asking a different question about supporting families rather than accusing them, we would be able to think differently about a combination of staff who would work with families, supported by social workers, but also by other peer advocates who would support a family, again, as opposed to just accusing them. So a different way of thinking about the issue, but I hope will help you think a bit more about how to develop a way in which to measure how a workforce might be effective. Thanks.
Thank you, that was great. I'm like, I've learned so much about that welfare system. It was a lot more connected and fascinating than you let on in the beginning, so kudos. So just to sort of start the conversation, I have 800 questions. But something that struck me, I think, as Jane spoke, and something that I sort of mentioned early on, and I think Helen and Jim brought it up in different ways. In the measuring the health workforce and measuring health, we were very much an output focused. I think in some ways punitive or accusatory at times. You had to reach quotas and things like that of our workforce. How did we progress from being, we didn't fully progress. How did we mostly progress from being accusatory or output focused to a more holistic supportive systems, I think, approach? And what did we have to do to get there? There's issues around data collection, and I would say stakeholders is a big part of that. So I guess I pose that to, I'll start with Jim, but I pose that to you all as to how did health manage to sort of make this transition, and how could legal and other systems make that similar transition to a less accusatory system?
That's a really good question. I don't know. I mean, I think it was because when they first started getting data at the country level about, like that map of Uganda, I think people then within the Ministry of Health made some judgments about what were the causes of this, and tried to take some action, and that some of that action was supported in some cases by donors of various kinds. And the initial results of this didn't work very well. So I think at the time, this would have been 2004 through 2007 in different countries, I think they basically said we needed to take a step back and maybe look at this more holistically and say what other factors are at work and how do we get more qualitative data that could better inform our investments. Because I think they saw the investments not reaching either the workforce goals or kind of health outcome goals. And so that's what I would say. I mean, I think there was a switch to where they began to say we need more qualitative data, and we need it to inform us. And I was thinking about in both the other two presentations, I think there is sort of a principle here, and the principle is if you have a bad system or bad system elements, even if you have good people, the bad system elements win. That it discourages, it demotivates, it causes people who aren't trained to do things to do them badly, and the best that can happen is you get positive deviance. And that is people that somehow struggle through all that and end up doing really good work despite all that. But that shouldn't be what happens within the system. Anyway, that was my response to that.
Yeah. Jessica, could you ask the question again?
There was a question there. I guess what I sort of took from the presentations was that in health we've made somewhat of a transition of measurement systems that were more punitive or output oriented in nature. You didn't meet your quota, that kind of question. And how can we apply that to legal or other social welfare areas, help them to transition their measurement systems to more supportive and less punitive output-oriented systems.
Well, it's interesting because I do think this is happening in child welfare in other places. I mean, I think in Great Britain right now, some really creative work is being done, following Eileen Monroe's report, and I think there are some. I mean, it's not the only place, but I think but it requires a redefinition of the work that is being done with families. So
It's happening here too.
it is, but it's happening here, but it's happening here within. I think part of the problem here is it's still happening within a basically unchanged system. As long as we have a mandated reporting system, it has to happen within that system. And it's not happening within it doesn't start with prevention. It should start with prevention, but I don't think it does. Because I think that there's tremendous societal pressure to start with reporting. It doesn't mean within that system people aren't doing good work to try to work with families. But there is tremendous pressure to investigate. And that's,
Yeah. So you're measured by your investigations or your, yeah.
I think that
no.
No, it's Mailman.
Yeah.
Switching it on.
I think just to follow up really on what Jim was saying and what we've been seeing, and certainly in the task shifting world, is this understanding, and while there's still this need to do the kind of proof that task shifting or proof that reframing how people think about who can do what, there's still that need for that. There's still the convincing of the Ghana medical person that you referred to, that, you know what, it's not second rate to have somebody who can provide that care than the alternative, which is nobody. And I think how we frame these problems is really important, because it's always the comparison of the associate clinician versus the doctor. But when you say, well, there is no doctor, then how do we reframe that? I think that what we've moved on to looking at as well is a huge focus on implementation, of understanding how to do stuff. How do we change these systems? So it's not enough just simply to say you need good health workers and you need the enabling environment and you need all of these things to align. But what we try to understand, and that's really informed by a lot of qualitative and mixed method approaches, is, well, how do you get that to align? What does it take? Does it take one enthusiastic person? Does it take a committee that is going on? And that's really the work we're doing now in Zambia, is to understand how did they do that? And I think that as we figure out what needs to be done, how do we reframe this, who is available, the next step, and the why is there, the next step is then the how.
People are welcome to ask questions. If you do want to ask a question, go to the mics because you're being recorded. I am not from the NSA. So I have another question that comes to mind is for me, working in health, we can measure intermediate and other outcomes. And those outcomes are, I would say, fairly in the short term. People who have malaria, who get sick from this, deaths from maternal mortality and things. When you're talking about a social welfare environment, it's, I think, far more complex. There's a lot of different things at play here. And I think the outcomes are much more longitudinal in the sense that, you don't know if the child's benefited from the system until they're, 10, 20 years later. And I'm wondering, in an environment with limited funds, how might you go about getting at those longitudinal impacts and also very complex impacts without, although Helen, I was very impressed with all of your surveys, I kept the dollar signs were just going in my head. How do we get at those longer term effects in the system through either routine or survey methods or something? How do you follow a child for 20 years?
Well,
Anyone?
yeah. I mean, there is important work that's been done following children in the child welfare system, in the foster care system. Looking at outcomes, which of course are not very good. But they're, I don't know how much it tells us actually. It tells us. I don't know how much it tells us about. It's so complex that I don't know what it tells us other than as a system, it certainly tells us broadly, the state doesn't do a very good job of raising children. Children in similar situations at home are better off generally than children in care. That's yes, you can make these broad findings, and then of course there's very good research when you dig down, looking more closely at children of certain ages, and when removal is more appropriate, when it isn't. There's real stuff to. I'm not suggesting those kinds of measurements aren't, and those kinds of things are being measured and give us a lot of information about what we might be doing. I think what we don't have to compare it with is if we had a different kind of system, what would that look like? Although in other parts of the world there are different kinds of systems and they seem to work better than ours. So.
I have a quick thought about this, and I know it's just a question. Is this on? Okay.
Yeah.
I think even in the health arena, I think we're progressing, but we're looking at intermediate indicators, I think. And with workforce, it is things like, higher indicators around the hiring process. So if you're looking at a country level, and it used to take 9 months to hire a physician or a nurse, and you set a standard of we should be able to do this in 2 months, and we should take all the administration. So you could come up with intermediate workforce indicators. How that relates then to health outcomes, I still think we're struggling a little bit with, but I think we could have the same thing in the social workers. I think once you get some mapping made in these countries of who's doing what, where, at which level, you could then begin to say, well, at a minimum, at least we ought to aim for the intermediate indicators of filling certain kinds of gaps. It's not perfect, but I think you start where things are at the moment, and you start by this mapping, and even by defining. And I think it is harder in the social service workforce area, because in the end, malaria and prevention of malaria is something that is pretty universal, no matter what country you are. But I was just listening to Jane, your comments about just the incredible differences between states. If you have, in many countries, there's a decentralization process going on. And will some of these same things crop up in district level sort of situations in Zambia or in Kenya or something? It's just a question to think about.
I wanted to make comments because these things did all actually pull together in some way, even though you all kind of started talking and say, well, I'm not really related to the next person. They really did. And I think one of the themes that kind of came to me was this idea of people sort of working beyond their scope of knowledge. And that's part of also what happens in the child protection system in the U.S., the child welfare system, because you talk about social workers, but less than 40% of the people who do child protective service work in this country actually have social work degrees, even though the public thinks they're social workers. They are not, either at the baccalaureate or the master's level. And some states that could be 3%, 10%. So we have a whole system that's kind of set up on, well, what do we really need also, no matter how we define the work, what are the skills and knowledge that we need? And then the other piece of it really is this piece around what are the outcomes we're looking at. And there's been a lot of focus now really looking at well-being outcomes for kids in the child welfare system. A lot more talk than action, but a lot of discussion about it. And when you come down to that, then people start talking about all the health, mental health, and psychosocial efforts that need to take place in a social service system to actually get to better outcomes. And then you start once again saying, well, who are the kinds of staff we need and what kind of qualifications they need to have and what kind of clinical skills they need to have. So we have a lot of disconnects that I think get created in the US and in other countries as well. And I think that from my conversations with people in Great Britain or in Australia or whatever, they face a lot of the same issues that we do so I think we're really sort of challenged to do this, and the sort of issues around prevention. I mean, we talk about it a lot, but we don't have financing mechanisms. So the issue of policy really becomes a factor as well, because we don't really have good financing mechanisms to finance prevention programs. We have great financing for foster care programs.
Right, I would just, I agree with everything you said, but I think that that's part of the problem is we've set up, if we have a system that focuses on not on what would keep children, most children, not all children, but most children safe in their communities, as opposed to a system that focuses on taking children out of their communities and putting them into a very expensive out-of-home system where we're going to spend all our money. So we're not going to train good workers. We're not going to pay for social workers to work in the community to not just social workers, but all the other kinds of resources that if they were in the community sharing tasks that would enable the community to be strengthened, then you'd have a small foster care system for those small number of children who needed to be there, and then a large community-based, well-run, well-trained system. But we don't have that kind of system, and that's, that really is my basic point, is we've created this whole structure. And when you talk about focusing on well-being, I think that's a terrible idea. And the reason for the child welfare system, and the reason is it's just putting more resources inside the system. We can't figure out now how to do safety and permanency. Now we're going to do well-being too. We can't do safety. The child protective system can't even keep children safe. Now we're going to add in well-being. I would rather just get them out and hope that if they were somewhere in the community, well-being might get focused on for, within schools, within mental health systems, within other systems, as opposed to now shifting even more resources inside. So, but that's mine, sorry.
This is fascinating. Murray is, and then we're short on time, as you can imagine. So it's you are the last word, unless it's a question, in which case you're almost the last word. And then of course we're all around, so you can talk to us.
Good.
Well, I just wanted to thank you all so much. I feel like this panel is kind of blowing my mind, and during the discussion, I'm kind of picking up the pieces a little bit and trying to put them back together. What I'm thoughtful about at the moment, I'm thinking a lot about outcomes, and I feel like you all have talked about outcomes in different ways in your presentations. And then during this discussion, we've kind of, Jim, you said something that made sense to me about kind of intermediate outcomes, and then we're also talking about protection and well-being outcomes, and those are ultimately the outcomes that we're working towards. But we need to have these intermediate outcomes. We need to both know what is the impact of our workforce strengthening efforts on the well-being and protection of kids, but also what is the impact of our workforce strengthening efforts on the workforce. But it's hard to know, do we need to have those well-being and protection outcomes really kind of concrete in our mind before we can come up with those intermediate outcomes? And what I have envied, I think, about the work that you all have done within health workforce strengthening is you haven't, well, also I feel like your final outcomes are a little easier to articulate. So I'm definitely envious of that. Definitely envious of that. But also I'm sure that there's still some controversy around that, but I think that you haven't allowed yourself to get so hung up on that you can't come up with these outcomes that help you to do this really powerful advocacy. And one of the outcomes that I'm really envious of is this ratio. This mysterious ratio. And I wanted to know just if you could give us any insight into that ratio, because what I hear from my colleagues who work in Africa and other parts of the world is a lot about ratios, and what should our ratio of social workers to population be? What should our caseload ratio be? And these are really hard things, and probably not things that we're going to come to consensus around anytime soon, but I wish we could.
We had
The ratio she's referring to is the WHO ratio, 2.3 sort of doctors, nurses, and nurse midwives per 1,000 people. That's a very interesting history. That took at WHO a year and a half of experts from various parts of the world arguing and looking at things and trying to relate this to health outcomes. And there was lots of internal controversy around how solid this was at the time. But there was a driving sense of urgency that we need something. And they had already decided to devote the World Health Report in 2006 to this whole issue. So there was a deadline and a sense of urgency. And then they basically said, this may not be perfect, but it's the best we can do at this time. It doesn't, for example, deal with distribution. So you could say, well, in this country they have over the ratio of 2.3, but almost 90% of them are located around the 2 largest cities, and there's nobody in rural areas. But it didn't matter. What they finally decided is we need to forge ahead, take that, and run with it. And it's proven to be really, really important for advocacy at the global level, but also people at the country level said, this is so important for us because we can go to our decision makers and policy makers and say, here's a global standard. So in some ways, I think for the social service area and the workforce area, we just have to forge ahead with it and to do the best we can and to pick out and maybe do the same thing they did, is convene, and I know there's some work on this, convene a group that basically says, we're going to do the best we can to come up with some reasonable standards that we can use as an advocacy tool. 5 years from now, or 7 years from now, we may change it with more sophisticated data, but we need something. So I agree with you, just 100%. I mean, it is a little, you'd think it would be a little easier. It was really hard even in the health area, so it's going to be harder in this area.
Can I just add one point to that? I think that 2.3 was great, except for associate clinicians, because they actually were not counted in any of that. So it's really interesting when you have a country that depends on associate clinicians for their clinical care, and then the ratio is just about the number of doctors or doctors and nurses. And so I agree with Jim in that having a number was useful, because it's a big problem. Whether you included associate clinicians or not, it's still going to be a big problem. So you want to have that big problem, and now you need the kind of more textured understanding of who actually is or isn't counted.
but you create that sense of change.
Yeah.
You need a sense of urgency and that big problem. And I think, that was what it was useful focusing on.
So we're going to wrap up this session, and I'm very glad that we brought it back together with stakeholders and data. Has really been worked together, so that makes me happy. I think we're taking a short break between sessions, and then you'll see me in the office. Thanks.